Hello everyone, welcome back. In today's lecture, we'll be moving on to Vent 104. And under Vent 104, we're going to be covering another very important mode of ventilation, which is going to be pressure controlled ventilation, PCV. And this is also called ACPC. And ACPC means assist control, pressure control. So let's break down all these big terms. So starting with assist control ventilation, which is AC. What does that mean? So this is the mode whereby every breath gets full ventilator support. Either the patient initiated it, so that's going to be assist, or if the ventilator initiated, then that's going to be what? Control. So the assist is going to be patient initiated, and control means ventilator initiated. And then let's go to the other part, which is PC, which is the pressure control. So what does that mean? So that means how that breath is going to be delivered. Either the patient initiated it or the ventilator initiated the breath. How that breath is going to be delivered is going to be what? Pressure, right? So the ventilator will deliver the breath to a set inspiratory pressure. So you have to set that pressure. So that's why we call it pressure control for a set inspiratory time. Remember, as opposed to the volume controlled ventilation that we spoke about in the past, whereby you have a preset tidal volume. So you set the tidal volume in that case. But here, we're going to be setting the pressure. So that means what is going to be variable is going to be the volume, your tidal volume. So the tidal volume will depends on the lung compliance and airway resistance. So that means if you have a patient on a pressure controlled ventilation, so that means if there's a changes in the lung compliance or in the airway resistance, that could affect your tidal volume because the tidal volume is not fixed. So that's why in pressure controlled ventilation, your volume is not guaranteed because it depends on the lung compliance and airway resistance. So in summary, in pressure controlled ventilation, pressure is fixed, but tidal volume varies depending on lung compliance and airway resistance. So now let's go through the phases of pressure controlled ventilation. Remember, we went through the phases in the past, in the previous lecture. So in pressure controlled ventilation, the first thing there is going to be trigger. So what's going to trigger this? The breath. So trigger is what initiates the breath. Like we mentioned earlier, the trigger could be a patient triggered, in other words, patient initiated, or it could be a ventilator initiated, which is going to be a time trigger. And under patient trigger, so how will the ventilator knows that the patient wants to initiate a breath or needs a breath, right? So the ventilator will look for changes in the airway pressure, right, or flow. So if it's going to be drop in airway pressure, then that's going to be a pressure trigger. And if it's going to be change in flow, then that's to be a flow trigger. And then once the ventilator senses this, then how is the breath going to be delivered? Because this is a pressure control ventilation, that means the pressure will based on your inspiratory pressure. So that will deliver the what? The breath, right? It could also be time triggered, which is going to be the ventilator initiated. And this is going to base on your preset respiratory rate. So based on the respiratory rate that you set, that will determine how frequent the breath will be delivered. And same way, the way the breath will be delivered will also be what? Based on your pressure, right? So pressure, because it's a pressure controlled ventilation. So which now leads us to target. So now, once there's a trigger, then there has to be a target. So what does target mean? Target means how the breath is going to be delivered, right? So because this is a pressure controlled ventilation, the way the breath is going to be delivered will be with what? Pressure. Very good. So the ventilator will target a preset inspiratory pressure, right? And remember what we said earlier, what's going to be variable here is going to be your volume or flow, right? Remember flow is volume over time. So this is going to be what? It's going to change from breath to breath or even based on the lung compliance and the airway resistance. And then moving on to the next one, which is going to be cycle. So what's going to be cycle? So this is what ends inspiration. And so in pressure control ventilation, what's going to end the inspiration is going to be what? Time. So time is going to end it. So inspiration ends after a preset inspiratory time. So you have to set inspiratory time, and once that inspiratory times elapse, then that ends the what? Inspiration. And this is not a volume cycle. Remember, as opposed to what we saw for volume controlled ventilation. So now let's now look at key settings. So we've talked about the theory. So let's look at some practical, right? So what are the key settings we need to set on pressure controlled ventilation? So like you said, you have to set your inspiratory pressure. So you have to set the inspiratory pressure. So this pressure, the ventilator will deliver during inspiration, right? And this is usually set above the PEEP. So sometimes we call it pressure above the PEEP, right? The next thing you need to set on this mode is going to be your PEEP. So which is positive end expiratory pressure. Remember, that's the pressure in the alveolar at the end of expiration, at the end of exhalation. And that's the pressure that keeps the alveolar open. And that normally help to decrease work of breathing, and it help with what? Oxygenation. And it usually ranges between 5 to 15. And the next one, you have to set your respiratory rate, right? And that's how many breaths per minute. And then you can adjust your respiratory rate based on the patient CO2 and patient what? Condition. Next, you have to set your I time, which is the inspiratory time. And it is the duration of the breath in seconds. And remember, we said that the I time is so important because that's what determines the cycle when the breath ends, right? When inspiration is going to end. And if you have a longer I time, so that means that will increase the tidal volume in pressure control ventilation because you're going to have more time for what? Inspiration. Next, you have to set your FiO2, right? Which is going to be the oxygen concentration. And this you can adjust it based on your oxygen saturation and your partial pressure of oxygen in the plasma, your PaO2. And then lastly, you may also have to set your trigger sensitivity, which is going to help the patient to initiate the breath, especially if patient needs to initiate the breath by themselves. And a set negative pressure or flow sensitivity. So let's look at a good example here. So on the mode, on your ventilator, you're going to select your pressure controlled mode, right? And then you're going to set your PEEP, right? So depending on patients' underlying pathology, right? If they have ARDS, they might require higher PEEP, right? And they're going to set the inspiratory pressure, which will normally start between 15 to 20, and that's above your PEEP. So you set your PEEP, you set your inspiratory pressure, and then you can adjust it based on your tidal volume, as we're going to see later, because the differences between your inspiratory pressure and your PEEP, that's going to be your driving pressure. And that driving pressure is what will determine your tidal volume. And then once you set that, you want to be looking at your tidal volume. So you want to make sure your tidal volume is adequate. And what tidal volume we normally target, so we normally target between 6 to 8 mil per kg of ID body weight. And of course, if patient have ARDS, you might need to go lower than that. So you might need to go between 4 to 6 mil per kg of ID body weight. And of course, you want to set the respiratory rate in that patient. So depending on the patient underlying pathology, you want to set the inspiratory time, usually 0.8 to 1.2. Remember, like we said, the longer the I time, that will give more time for what? Inspiration. So you might want to set it longer for somebody who have a poor lung compliance, because remember, with poor lung compliance, if the lung is stiff, right, you might want to have more time for what? For inspiration. And for instance, if somebody have very severe COPD exacerbation or asthma exacerbation, then you might need to set your I time, inspiratory time on the lower side, so that you can have more time for what? Exhalation, right? Also, you want to set your FiO2. So we usually start at 100%, and of course, you don't want to leave them 100% for too long. You want to start winning it down. So you want to titrate your oxygen based on your oxygen saturation or the partial pressure of oxygen in the plasma. Also, you want to check alarms and ensure the pressure limits are appropriate. And of course, like we mentioned, we want to observe the tidal volume, observe your airway pressure, and then make sure patient looks comfortable. That's very important. And you can adjust your pressure or I time as needed. So what are the things that we're going to be monitoring? Like we said, remember, tidal volume is not fixed. So you have to be monitoring the tidal volume. And then most importantly, we want to monitor to avoid for any volume trauma. And then make sure the patient is also not hypoventilating, because if they don't have enough tidal volume, that could lead to hypoventilation. Also, you want to look at the flow waveform. So make sure the flow waveform looks good, which we're going to talk about in a second. We also want to look at the minute ventilation. Remember, minute ventilation is tidal volume multiplied by your respiratory rate. Also, you're checking your oxygen saturation, right, on the monitor. If you have end-tidal CO2, you're also going to be checking your end-tidal CO2, and you can adjust your FiO2 and your respiratory rate as needed. Also, you're looking at patient comfort. Make sure the patient is comfortable have sedation on board if they need sedation, and then make sure they are synchrony with the ventilation. And like we mentioned earlier, driving pressure, because driving pressure is what's going to determine your tidal volume. And that driving pressure is going to be the differences between the inspiratory pressure that you set minus your PEEP. So that differences between both of them, that's going to be your driving pressure. And that's what determines the what? The tidal volume. So if, for instance, if there's a change in patient's pathology and decide to go up on the PEEP, remember that will decrease your driving pressure. That might drop your what? Your tidal volume. In the same vein, if you have a patient that you put on pressure control ventilation and there's a decrease and they not get enough tidal volume, then you might go up on the we might increase your inspiratory pressure so that you can increase your tidal volume to be able to achieve so that you can increase your driving pressure to be able to achieve your target what? Tidal volume. And of course, you need to keep eyes on those tidal volume. Moving on, guys. So this is a good waveform of somebody who is on pressure controlled ventilation. So when we look at it, so the first waveform there is going to be the pressure, the next one is the flow, and the third one is going to be the volume. And remember, like we said that flow is volume over time. And the one thing I want us to appreciate here is, for instance, let's say they didn't even tell us that this patient is on pressure control ventilation. But by looking at this waveform, so if you look at the pressure waveform, you can see how regular they are, right? So they are squared, right? And they are very regular. And as opposed to volume, you can see the volume is changing from breath to breath, because this is going to be inspiration, this is going to be exhalation, inspiration, exhalation, inspiration, exhalation. And you can see that your volume is changing from one breath to another breath. So that tells me that the volume here is not controlled. And what's controlled here is pressure. So that tells me that this is a pressure control ventilation. And if you look at all these breaths, you can see from the beginning of every breath here, I don't see any negative deflection. So because I don't see any negative deflection, that tells me that this is what? A ventilator triggered or time triggered, right? Because if this is a patient trigger, you might appreciate a negative deflection. And of course, some ventilator will tell you if it's an assist or a control breath in those patients, right? And then, and in unlike volume controlled ventilation, whereby we can easily check plateau pressure, we can easily be able to assess. We don't have that opportunity here to be able to be monitoring plateau here. But one thing, the flow, understanding the flow very well and the volume could give you a good idea of if there's any changes in patient's underlying pathology. For instance, if patient is having, for instance, let's say they're having ear leak. So for no reason, let's say they have a patient develop bronchopleural fistula, or there is your ET tube, the cuff of the ET tube busted open, and now when the air goes in and when the air is coming out, instead of the air coming out through the ET tube, the air is coming out around the ET tube. So how am I going to be able to assess that? By looking at this waveform. So if you look at the flow waveform, so what you can see is that during inspiration, right, there'll be no problem. But during exhalation, right, instead of the air coming out, so this waveform, so the exhalation waveform is going to be what? Decreased. So when you look at the volume waveform, so you can see this is going to be the inspiration, but during exhalation, the volume will be what? The volume will be decreased. So you can see the volume is decreased, and then towards the end, there's going to be a drop. So you're going to see it doesn't return back to zero. There's a sudden drop. So when you see that, that could be suggestive of what? Of maybe the patient has what? Air leak. So that's one pathology. The other thing that you can also be able to look at the flow waveform and the volume waveform that could give you an idea is what about if somebody is having worsening in lung compliance. So if somebody is having poor lung compliance. So for instance, patient is developing worsening ARDS. So with worsening ARDS, what's going to happen? Like we know with ARDS, if there's a lung compliance, so that means the lung become very stiff. So that means if the lung is stiff, that means we're going to be having problem opening the lungs. So it's going to be a problem with inspiration. And then because of the lung is now stiff, the elasticity is increased. That means the exhalation will be what? Will be very short. Remember, because of the increase in elasticity, the lung recoil is going to be high. So that means when you look at the wave, when you look at the flow, so number one, looking at the flow, the expiration or the exhalation waveform of the flow will be what? Will be decreased. So when you look at it, instead of it going all the way, so it's going to be very what? It's going to be very short, right? So that's one way. And number two, of course, because of the poor lung compliance, if the pressure, inspiratory pressure remain constant, that means your tidal volume will also be what? Will also be decreased. So if you see decreasing tidal volume, and if you see, look at the acceleration of the flow waveform, and it's very short, that could be suggestive of what? Worsening lung compliance. What about if somebody have problem with increased airway resistance? So increased airway resistance. So example of increased airway resistance could be somebody who have COPD exacerbation or asthma exacerbation. So remember, with COPD or asthma exacerbation is a problem with what? Exhalation. So because it's a problem with exhalation, so that means when you look at the flow waveform, the exhalatory phase is going to be what? Is going to be prolonged. So the exhalatory phase is going to be prolonged. And of course, when you look at the tidal volume is also going to be what? Decrease. So when I look at this waveform and I see a decrease in tidal volume and I see a prolonged in my exhalatory phase, that could be suggestive of somebody who have what? Increase in airway resistance. So that's how you can kind of like look at this waveform to be able to twist around different pathology. So let's now go through troubleshooting of pressure control ventilation. So if, for instance, the vent is alarming low tidal volume or poor ventilation, so this could be signs. So the tidal volume is lower than expected, or there is high end tidal CO2, which means that the patient is hypoventilating. So this could be due to maybe your inspiratory pressure is too low, because if your inspiratory pressure is low, that means your driving pressure is going to be low. So you want to check your inspiratory pressure versus your PEEP. Remember, driving pressure equals to your inspiratory pressure minus PEEP. And the higher it is, the more tidal volume you're going to get, right? So if your inspiratory pressure is low, you want to make sure it's not too low. So you might need to increase your inspiratory pressure to be able to achieve your target tidal volume. Also, it could be maybe there is a poor lung compliance, so the lung is becoming stiff, or there is ARDS. So that could be the reason why the tidal volume is dropping off, because remember we mentioned that in pressure controlled ventilation, the tidal volume is what? Is variable depending on the lung compliance and airway resistance. So in that case, you might need to increase your inspiratory time so that to allow more time for the lung to what? To fill, and you might need to adjust your pressure. Also, what about if there's airway leak? We just mentioned it earlier, maybe because there's ET tube cough leak, or there's a break in the cycle. So you might be hearing audible leak and the tidal volume is inconsistent. So in that case, you might need to, if it's the ET2 cough there's leaking, then you might need to exchange that ET2 for a new what? ET2. And of course, you want to assess your cycle, make sure there's no break there. What about if there's high airway resistance like secretion or bronchospasm? So of course, patient could be wheezing, they could be having high peak airway pressure. So of course, you want to suction those patients, you want to give them bronchodilator, and then you might need to drop the respiratory rates, right? So you want to drop the respiratory rates to allow more time for what? Exhalation. What about if there is a patient vent asynchrony? So patient is not synchrony with the vent. So for instance, patient is fighting the ventilator, there's double triggering. So in that case, you might need to adjust what? So you might need to look for the cause. So for instance, you can look for is the trigger sensitivity too low or too high? So you might need to adjust that. You might need to look at the inspiratory time if there's a mismatch in that, or does the patient need more sedation, right? Or is the flow needs unmet? So in that case, if patient is having flow starvation, then you might need to increase the inspiratory pressure to be able to meet with the patient what flow. What about if there's hypoxemia, right? So that means there's so the sign could be low oxygen saturation, or when you do your blood gas, you look your PaO2 is going to be low. So in that case, you might need to, if they have low FiO2, you might need to increase the FiO2 to be able to achieve that. And if they're on a low PEEP, you might need to go up on the PEEP. Remember, FiO2 and PEEP normally up with what? They normally up with oxygenation. So you might need to increase either your FiO2 or PEEP. And of course, if they have poor ARDS, other thing that you can do recruitment maneuver, you can prone the patient, you can add pulmonary vasodilator. So depending on the severity. And if it's hypercapnia or respiratory acidosis, so you want to optimize your minute ventilation. So you can either increase your tidal volume or respiratory rate. And how are you going to increase your tidal volume? Yes, you have to go up on your inspiratory pressure. Very good. Or you can increase your high time. So again, comparing pressure control ventilation with volume control ventilation. So in terms of trigger, so for pressure control ventilation, so it could be patient trigger or time trigger based on the respiratory rate you set. And in terms of target for pressure control, is going to be what? Pressure, right? Remember, as opposed for volume control, is going to be your preset tidal volume. And in terms of cycle, what's going to end the the inspiration. In pressure control ventilation is going to be time, and in volume control ventilation is going to be what? Volume. And in terms of tidal volume, remember in pressure control ventilation, your tidal volume is not fixed, so it's variable depending on the compliance and resistance. As opposed to in volume control ventilation, your tidal volume is fixed and guaranteed. In terms of airway resistance, the airway resistance in pressure control ventilation is fixed or limited, right? Because you set the pressure. Whereby in volume control ventilation, it could be variable. And when you look at the inspiratory flow pattern in pressure control ventilation, it's usually decelerating, but in pressure control ventilation, it's usually a square waveform. And when you look at the mini ventilation, it's guaranteed because you set your tidal volume and your respiratory rate in volume control ventilation. So your mini ventilation will be guaranteed because remember, mini ventilation is respiratory rate multiplied by what? Tidal volume, right? So both of them are set in volume control ventilation, whereby in pressure control ventilation, it could be variable depending on patient lung compliance or underlying pathology like airway resistance. And a peak airway pressure is usually lower or controlled. So that's why sometimes people love pressure control ventilation. But in volume control ventilation, it could be higher. And a plateau pressure, similarly, is also lower in pressure control ventilation and may be increased in volume control ventilation, depending on patient pathology. And of course, in pressure control ventilation, there is a risk of hypoventilation because if there's a worsening in lung compliance, then the tidal volume could be decreasing and that could lead to hypoventilation. Whereby in volume control ventilation, you worry more about barotrauma. So we've come to the end of today's lecture, guys. So let's do some questions. So the first question there, which variable is not fixed in pressure control ventilation? Remember, our tidal volume is not fixed, it's variable. Next question, a 45-year-old man with severe ARDS is ventilated on pressure controlled ventilation. Setting, so we have our pressure controlled above the PEEP as 15 and the PEEP is 10 and respiratory rate is 20. We have our I time as 1 second. Over the next hours, the tidal volume falls from 420 to 280 and the peak pressure is unchanged. What's the most likely cause? So most likely this patient is having what? Likely having worsening lung compliance. So there's worsening lung compliance, which explains why the tidal volume is falling and the peak airway pressure is unchanged. So the best answer there will be B. Moving on to the next question. A ventilated ICU patient on pressure control ventilation has persistent hypercapnia despite adequate tidal volume. Which adjustment best improves the CO2 clearance without increasing the risk of trauma risk? So in this case, you don't want to be going up on the tidal volume. We already have adequate tidal volume. So what else we can do to optimize our CO2, right, is to optimize our ventilation. And remember, we said that minute ventilation equals to what? Equals to respiratory rate multiplied by what? Tidal volume. So we've optimized the tidal volume. We still have a room to go up on the respiratory rate. So the best answer there will be to increase respiratory rates. In pressure control ventilation, increasing PEEP while keeping the inspiratory pressure constant, we do what? Remember, we said that driving pressure equals to what? Driving pressure equals to our inspiratory pressure minus PEEP, right? So that means if I'm increasing PEEP and I'm not changing this, what happens? That will decrease driving pressure. And the driving pressure determines the what? It determines the tidal volume. So that means in that case, the tidal volume is going to decrease. Next question, in a pressure controlled ventilation pressure waveform shows a squared inspiratory plateau, but the flow waveform has reduced peak with prolonged expiration. So there's a decrease in tidal volume. So the tidal volume is decreased, and if you look at the flow waveform, guess what? There's a prolonged expiration. Like we said earlier, in what type of lung pathology do we normally have prolonged expiration? Very good. So that means that patient has what? Increased airway resistance. So there is an obstruction pathology. So this could be an asthma exacerbation or COPD exacerbation or somebody who has a mucus plug, right? Any of those that could cause what? Obstruction to airflow. So the best answer there will be what? Will be increase in airway resistance. Because remember, if this is supposed to be worsening in lung compliance, if this is supposed to be decreasing lung compliance, remember, even the tidal volume will be decreased, but the expiration will be what? Will be shortening. So we're going to have a short expiration. Very good, guys. Moving on to the next question. In pressure control ventilation, the tidal volume drops suddenly and pressure waveform remains unchanged. and expiratory flow shows continuous low level flow throughout the exhalation. So during inspiration, there's no change. But during when you look at the expiration flow waveform, so when you look at the flow waveform and when you look at the expiration phase, that's when there's a decrease. So this tells me that there is no problem with air going into the lungs. It's when there is air coming out, that's where the air is disappearing to somewhere else instead of coming to the what? To the ventilator. So this tells me that this patient is having what? Air leak. So it to be a great example of air leak. So you can see there the pressure waveform remain the same, but it's the expiratory flow that shows continuous and low level flow throughout the expiration. So that will be a classic example of air leak. And let's go to the last question. In pressure control ventilation, which waveform change indicates improving lung compliance? So if the lung compliance is increasing and you are not changing your inspiratory pressure, guess what? That means if the lung compliance is improving, guess what? Yes, the tidal volume will be what? Increasing. So they want to be increasing tidal volume even at that same what? Pressure, because your lung compliance is improving. Thank you guys. We've come to the end of today's lecture, guys. Please don't forget to like, subscribe, and share this video with your friends. And I will see you guys in the next lecture. Bye for now.